So this presentation I'm going to share with you, ideally we would need about 2 hours to go through it, but what I'd like to do is just run through some slides that shares with you a bit of an assessment that I did against a draft Australian anti-stigma strategy. So in Australia, they had taken the decision to create a single strategy that looks at stigma and discrimination in mental health and how to tackle it. And I was really curious just to see if we could benchmark ourselves against that. So it's not the some words of caution. It was a very, it's an assessment that I did, so it won't be wholly objective. And it wasn't as rigorous as I would have liked it to be. But hopefully it'll give us some insights and food for thought when you come to know what you believe the actions that need to be taken now in Scotland. Hopefully it'll help with that. Nick? Can you move us on, please?
Yeah, I've done. I'm on to do you want the common themes slide?
I've not got it. It's not shifting on my screen.
Oh, is it not?
No. Okay, I've got it now. Thanks. So there was common themes that are coming through. What's curious is that both countries have had long-term investment from the government, both with national commitments to tackling stigma at all levels, exactly what we've been saying by way of a system-wide approach. The strategies make a case for immediate and enduring effort to reduce stigma and discrimination, and particularly for those who experience mental ill health, trauma, distress, and suicidality in their families. There is a central role of lived experience driving forward change. So there's definitely a real passion to ensure that happens. And both strategies are intentional and authentic about collaborating in a way that can really drive forward change. Both are saying there's an emphasis to achieve change at scale. We need to be ensuring this collaboration. Both strategies have similar commitments in respect of being human rights based, to say that actually if we were human rights in our focus, discrimination would not exist. Both carried out national mental illness stigma studies, so we actually used Australia's stigma study and implemented it here in Scotland to see. So we've got very similar data sets in respect of the themes and the issues that are emerging. And Canada have run a similar study, and again, there's some common themes, but we could have a session on that in its own. Both are saying it's about addressing the systemic inequalities that people experience, and in particular by the most marginalised groups, is the way it's described, and working across government policy areas to address. And what's interesting is Australia are setting out their stall around public, structural and self-stigma to end mental health discrimination, and creating a society and culture where all people have equal dignity, respect and value, and are able to live free from stigma and discrimination. Next slide, please. So that's the common themes. The next slide will show you where there's a, oh, it's gone, but there's a slide that tells us the difference, isn't there?
So there's there's the general reflections, the differences.
I'll just move on. We'll use this one. So similar approaches and priority areas for focus are identified, which is not, can you go back again? Sorry.
Sorry, there must be a lag on the thing here.
Yeah, thank you. Similar challenges identified and at similar stages of development. There's been action framed, so but all our action really is similar in the sense that we're using the same type of evidence base for what we're looking to do. And what it's encouraging is saying that anti-stigma work can happen in its own right, but equally it's part of ongoing legislation, policy and practice development. And it comes with real strength to trying to understand what's already in train and track what difference it's making in respect of reducing stigma. There's opportunity to influence system-wide change, building on what's already underway through a cross-policy approach. And I think there's value in taking a coordinated strategic approach to addressing stigma and discrimination, hence the reason why we're having this expert group in the first place about what would that need to include, what would that need to consider. And there's strength in sharing responsibility and accountability for it. There is a critical question, and I think, Jane, you referred to it earlier, about how will we know we made a difference over time? So what data are we collecting? What trends are there that we're able to describe and share? And how will we know that what we've done has achieved the impact, the outcomes, and actually involve the people in a way that's important to them? Next slide, please. Core differences, one strategic action plan versus several. So I would say that having a strategic action plan for stigma is helpful because it sets out the stall really, whereas we've taken an approach in Scotland to have separate strategies, all with an ambition of reducing stigma, which is great, but it means there's a bit more coordination required to ensure that happens. I think they've also got a common understanding. So they have a terms, a description, definition, a glossary of terms that is they've worked really hard with many stakeholders to develop that. But some of our definitions are slightly different across our policy. The types of stigma, as I said, they focused on self, structural and public, whereas we've got lots of different, where we set it in the context of intersectional stigma, etc. So we can come on and look at that in a bit more detail. And the levels of intervention, I think, are very similar in some respects, but actually what they've done is they've really majored on structural stigma and the ways in which self-stigma is fed by public stigma. And I think there's also a view around lived experience that actually to make that happen, it doesn't happen by accident. So if we're serious about driving forward an approach to stigma that has lived experience at its core, then we've got to make sure that the system's right and ready for that. And also that people are supported to do so safely, fairly, and that there's remuneration for their contribution. So I think there's definitely some differences in terms of what Australia's doing against what we are doing broadly by way of the actions that they're looking to take. Next slide, please, Nick. Thank you. So strengths in Scotland, of course, I'm going to say, see me having a national programme as part of a system-wide influence and change. But I think seriously, there is an opportunity for CME to have leadership, coordination, influence testing, sharing, learning role and much deeper into doing so. Strengthen organisations and partnerships. We've got incredible commitment to taking forward anti-stigma approaches across a whole range of different partnerships at different levels. Stigma across the life course. I think, as somebody's already said, we're starting young and working right the way through the life course. But what does that mean in terms of specific actions for stigma that you might take at different points? Focus on addressing the system-wide inequalities that lead to mental health stigma and discrimination. Legislation, we've got a power of legislative levers and drivers that should, in theory, make a real difference in terms of stigma and discrimination. But I guess there is something about, are they, and do we know, and in what ways? And then there's the new legislation that's emerging, coming through, that's really valuable and important that we get it right. Multiple national policies and priorities, I don't need to tell you. I've just lifted 3. One that's the promise around young people in care, fair work is another example, and the public health priorities in respect of really trying to drive forward systematic approaches to addressing inequality. And all of these and many, many more will have a role to play in addressing stigma. Ambition and action on public service transformation. So we've got lots of commitments and lots of activity around mental health service standards and primary care transformation and redesign. How do we know that those things that are in train are actually going to reduce mental health stigma and discrimination? Can we be sure? The lived experience point, again, about how do we ensure that we've got brilliant structures, processes in place, but it's not uniform across the country. And ambition and action in workforce learning and development. There is a workforce plan that supports the mental health strategy, and I think it's helpful in terms of really trying to understand what is the workforce requirements in terms of their capacity to be able to influence the change in the way that we hope. Next slide, please. Comparative challenges in Scotland. So I think it's how do we realise that vision and aspiration that we have from all of these strategies at all levels? we have pressures in the delivery context. So, you know, we know that services are already overloaded, overburdened, and I'm saying services, public services generally, not meaning mental health services specifically. But how do we do that? How do we create leadership for that cultural and practice and behaviour change that's required if we're going to reduce stigma? How is it resourced? So I think what we're also realising is in some of the work that we've done where it becomes core to business, where it's rather than additional, I think there's real power in that. So taking it forward as part of mentally healthy workplaces or mentally healthy schools, as somebody's already suggested. And structural elements of the health system, I think, are going to create some, but they do create some challenges for us. And it's been a long-term investment and commitment to try and influence some of these big system structural challenges that people who are living with more complex mental illness really find it hard to navigate. How we realise some of these broad ambitions around human rights and quality of life, and addressing, as we say, the most systemically marginalised groups. Coordination of action across policy areas within mental health and broader, and how we build capacity to ensure that that life course approach can be taken forward in terms of a universal offering, but also targeted and specific. And then how are we going to monitor governance and hold people to account? And I think these are all critical questions. If we're setting out this ambition of making a difference around stigma and discrimination, this self-assessment really helped me to draw out some of the critical factors we need to be thinking about, I think.
Wendy, I think you might just hit your mute
Yeah,
button.
I did, sorry. So
I just guessed that you were saying next slide though, so hopefully that was right.
Improving the evidence base through data research and evaluation. Again, it's been mentioned before. Do we have the data? Are we able to tell the story at population level? What is the prevalence and experiences of mental health related stigma and discrimination? Can we track improvement? What are our indicators for success and how will we know we've made a difference? What is the research that's required? The research that we've got, is there a repository? Do we gather together the research and the evidence, and how do we support for evaluation? So I think these are all just questions that I'm just sharing with you from my self-assessment of our approach that hopefully will generate some ideas for you when you come to record actions. Next slide, please. And this slide is around the building capacity for action. One of the things that really struck me about the Australian strategy when I was reading through it was that every professional group required some sort of capacity building to first of all understand stigma as an intersectional issue and then consider what their role is in terms of addressing some of that. But in order to do that, we need some leadership for cultural change. It's really clear that that's what the evidence base tells us. We need positioning and prioritising of stigma within these broader approaches. We've got to try and ensure that it's foundational to mental health improvement overall. And we've got to build the knowledge, understanding and skills, but move beyond just that to actually the cognitive and affective elements that often it's the social contact part where lived experience really brings that into the mix. And I think that's absolutely essential in terms of anti-stigma initiatives. I think somebody's already suggested this, that there should be and could be mandatory elements that are part of multidisciplinary training, both initial training but also CPD. And training that involves an appropriate level of nuance and detail to distinguish between the types and experiences of stigma that people experience it. And also how to plan and ensure that we are focusing on mental health stigma reduction, because I think there's a danger when something becomes the responsibility of all, it suddenly isn't anybody's particular responsibility. So how do we plan, evaluate, and be able to share our experience and what difference has been made? Next slide, please. Yeah, and lived experience, leadership and engagement. As I say, the Australian strategy was really strong in this regard. And I think what it guides us to think about is there are common elements in both. So we're hearing lived experience, leadership and co-design is essential if we're going to tackle stigma and discrimination. And I think that's really positive, but there is a question about how. Lived experience-led training across services, embedding peer support workers. So these are all things that are muted or noted within both our strategy in Australia. Also about collective and individual advocacy, social movement, service improvements and redesign, ensuring that contact-based initiatives are driving forward change, that we've got lived experience contributing to the elimination and stigmatising language in policy and media. And so it's really ensuring that it's woven through all the parts of a system-wide approach. But as I say, there's real challenges for us in that how do we make that happen? How's it resourced, the process for embedding, safeguarding and achievement at scale, for remuneration and value and for tracking impact? So again, just some questions. Next slide, please, that I had when I was reading through the different approaches that we have. And I think, again, this has been mentioned several times, is that we can't take an approach around mental health stigma that doesn't sit in the context of intersectionality and the interplay with different people's identities, characteristics, who they are as people and how they interact and the ways in which they are systematically discriminated against due to race, due to sexuality, so there's all sorts of things that we need to be considering. And again, you know, we've noted here that there's common aspects across both countries, but the challenges really, I think, come through for me around how do we ensure that we are driving forward with an approach that's authentic, sensitive and targeted, where there's low levels of cultural competency that's impacting on people's safety at the moment and their levels of engagement. The accountability, how do we ensure that it's mainstreamed, it's targeted, etc., particularly in mental health services, but much more broadly. I think people already suggested about the inequity and the over-representation of particular groups within mental health services. What are we doing in order to reduce some of that stigmatisation and discrimination? And how do we create safe and provide culturally safe services, not just mental health services, but across the piece, to ensure that everybody really gets what they need and it's tailored to suit their particular needs and circumstances. So I think equality, diversity and intersectionality was discussed in a lot of detail at the workshop at the last meeting that we had, but I'm really, I think across like all of these themes, it'd be really good to hear about your thoughts. I wanted to share the next slide is just an illustration for those that are interested in this. And I would be happy to follow up with anyone, but I've looked at each of the life areas in a little bit of detail, and I've looked to see what the common problems were, what the common ambitions are, and what I determined the key challenges might be. So that might help us to bottom out some actions as well. And I've done that for each of the life areas. I'm not suggesting for a minute I run through these because there's about 8 or 9 life areas, so it's far too detailed for a short presentation. But hopefully it gives you a sense that, because the next theme is healthcare services and workplaces and community and education and social services, housing services. So you can see we've got a lot of data that tells us what the issues are, what the ambitions are, and where the challenges, so therefore the actions might then follow. So that's a canter through. I'm really sorry we don't have time to do this. We gave a little bit more insight, and at the longer all-day meeting, we focused on 4 themes that seem to be of most interest to the different people in the room. I wanted to end on this slide. So what I think we need to consider is if we're taking a system-wide approach, here's a really simple social ecological model. Now, public health specialists in the room, forgive me, but it lets you see this is what we're talking about, I think, when we're saying we want to take a system-wide approach to tackling stigma. We need to be working and thinking about all the different levels and how they interact. And I think, you know, tackling various types of stigma. Personally, I don't feel particularly strongly about by association, stigma by association. If we were to lose that, that would be all right. But actually, I think intersectional is something that we really need to hang on to as an overarching approach to tackling stigma. So that's my food for thought from a self-evaluation, and I'm really happy to take any questions or thoughts that you have. I'm sure your head's just go